morning, everybody. I thank the organizers for giving me this opportunity. And I'm Dr. Ritika Harjani Hinduja from PD Hinduja Hospital, Mumbai. I'm a radiation oncologist, and we begin. So the topic given to me was limited disease small cell lung cancer, and the topics to be covered are regarding radiation therapy, the selection of case, time, dose, fractionation, volumes, and results. So today we begin with small cell lung cancer. So what is small cell and then what is limited disease? So small cell, as we all know, is a neuroendocrine tumor and characterized by its rapid growth and early dissemination. And staging, we have been going through it for a really long time over the 2 days that, what is stage T1 and T2. So I would not go into details. But what we use in small cell, which is more clinically relevant, would be the Veteran Administration lung group staging. So that is limited stage and extensive stage. So what is this limited stage? And I would be covering the limited stage today. So patients with disease confined to one side of or hemithorax with or without involvement of the mediastinal nodes or contralateral hilar or supraclav nodes. So basically, what we think clinically is that whatever we can encompass in one radiation field curatively at a go, we would call it limited stage disease. So a very few numbers, only 1/3 of the small cell lung cancer patients actually have or present with limited stage disease. And all these patients, of course, considering their performance status, age, PFT, comorbidities, I would say performance status is the most important factor to factor in while deciding for treatment. But the most commonly employed treatment for them is concurrent chemoradiation. And these days, recently, in the last few years, we have come up with really true stage 1 and stage 2, wherein we have T1, T2, N0 tumors with mediastinal staging showing negative nodes. Then surgery and SBRT has also come up recently. So while we'll first talk about concurrent chemoradiation, which is used in most of the cases. So concurrent treatment is the standard of care and preferred. There were trials, the RTOG 9103, which compared concurrent versus sequential, and there was a survival benefit with concurrent setting. Of course, this is a standard rule, but then you have to consider your own patient, their performance status, and then vary. Giving chemo first or sequential may also be employed in clinical practice. Again, when we are doing concurrent, like in other sites, it's not always with day 1 of chemotherapy. So we generally have, as a rule, believe that early thoracic artery, RT, is superior to delayed thoracic RT when delivering concurrent chemoradiation. So we generally aim to start with cycle 1 of chemotherapy, that is cisplatin etoposide, or at least with cycle 2. However, as I said, as a general rule, do not wait for your chemo till you're ready with your RT. If you're not ready for your RT, go ahead with the chemo, give the first cycle, and you can start with the radiation in the second cycle. A very important lesson that I learned during my residency 8-9 years back was there was one patient of limited stage, very much curative. We had some scheme issues, waiting for the scheme approval. There were 4 days delayed, and the patient had a very drastic exacerbation of the disease. So small cells are that aggressive, and that was maybe one lesson that I have learned and is close to my heart is in small cell, don't even wait for that 1 or 2 days. Just start chemo at least, and then we will start with our radiation. So, and there are also data that, although we advocate start with cycle 1 or 2, if the tumor is too huge and you still want to go curative, starting with cycle 3 is also not bad as per a Korean study and did not really impact the outcomes. While most of our disease sites we treat with radiation once a day, small cell lung cancer is one site where, despite a lot of trials coming in to prove the contrary, the ideal recommendation is to treat twice a day, 45 grays, in 2 daily fractions over 30 fractions over 15 treatment days, so 19 total days. So we give 1.5 gray in the morning and 1.5 gray in the night, like that for 5 days a week and 3 weeks. So this came with the landmark study published in NEJM in 1999 by Turisi et al. So 417 odd patients, all receiving cisplatin etoposide. And along with concurrent chemo, radiation was started. So what they randomized into was 45 gray in BD fractionation, that is twice a day, versus 45 grays in OD fractionation, that is once a day. And there was a superior survival benefit with the BD fractionation. And in all aspects, the median survival, the 2 years and 5 years. The esophagitis, which is one of our concerns, was a little more for BD fractionation, but it was manageable. So implementation of BDRT, most of the busy centers in private or government, logistic issues, it's sometimes difficult to incorporate 2 fractions for a day. And then for the patient, we have to have a 6-hour fraction interval. So we want the patient to wait for 6 hours and then take or come again with the Mumbai traffic. I don't think it's reasonable. And then there are some concerns about increased toxicity, and proponents argue that, there is inferior dose in the Turici arm of the OD fractionation. So the utilization for BD has been low, 11 to 21% across US, and I would say a little lower in India. And so ever since 1999, we have been trying to come up with trials to prove OD is as good. One of the major trials was the CONVERT, which is a superiority trial design. So it had, of course, the chemotherapy remained constant, the cisplatin etoposide starting early, and day 1 of cycle 2, the radiation was intended to start in both arms. That remained constant, but we had 45 grays BD in the standard arm and 66 grays in 33 fractions, 2 gray per fraction, that is once a day treatment in the experimental arm. And in all cases of stable disease, partial response or complete response, going ahead with PCI in both arms, that is prophylactic cranial irradiation. So at a median follow-up of 45 months, median overall survival did not differ between the 2 arms. However, to know this was a superiority trial, so it failed to show superiority of the OD regimen. And the most toxicities were similar, except some more neutropenias in the BD arm, as that was the chemo aspect. But esophagitis and pneumonitis, which we give to the patient primarily, remains same. So there were some important conclusions from CONVERT. What they noticed was radiation-related toxicities were lower than expected, likely due to use of modern radiotherapy techniques in both arms. Survival in both arms was better than the previously reported, but it was a superiority trial. It did not prove superiority. And what inference was made into the ASTRO guidelines was for patients who are unwilling or unable to undergo twice daily RT, or in clinics where it is not feasible, which is in most clinics, daily RT of 60 to 70 gray is an acceptable alternative based on CONVERT. Then we did not stop here. There are trials to increase the dose in the OD arm and the BD arm. This is one of the trials. The abstract was recently presented in the ASCO 2021 meet of having a higher dose to a 70 gray. Again, that did not prove to be superior to 45 grays BD, but the outcomes were favorable. We come down to the same thing, that it was a superiority trial, but did not prove superior. Similarly, 45 grays is also considered to be a slightly lower end of the dose spectrum. So there were trials to actually think of higher doses, and that also showed that it is superior. But an ASCO post said that, that is just a phase 2 trial. The size is of the sample size was low, and it was a one-sided test of significance. So statistically not that robust. So even today, 45 grays BD is the standard of care. Hypofractionated was tried too, but not yet recommended. Treatment volumes. So basically, while we contour, we take the post-chemo GTV primary, or the primary gross disease, and the pre-chemo nodal volumes, and add a 5 millimeter margins. I think I have to rush a bit in lieu of shortage of time. And in case of a complete response to chemotherapy, CTVs can be contoured based on the pre-chemo GTVs. We generally do not have elective nodal irradiation in any lung cancer, small cell or non-small cell. Role of SBRT has recently come up in true early stage lung cancers. I'll take a minute or two. Can I continue? So true early stage, that is stage 1 and stage 2, where an invasive mediastinal staging has been done, SBRT can be now performed. Generally perform it before chemo because they will respond, and you wouldn't have a target to delineate if we do it after chemo. and not preferable for the ultracentral tumors. Again, post-op party, if we have gone very robust and gone ahead with surgery in these early tumors, there is some controversial though existent role for post-op party, where we treat the involved nodal stations and the bronchial stump and subcarinal station. So this is where majority of what I'm speaking along with the randomized trials come from, the ASTRO guidelines and the ESTRO contouring guidelines. Another small aspect what we consider in radiation for limited stage is the prophylactic cranial irradiation. So about 60% do develop brain mets eventually, and with this rationale, prophylactic cranial irradiation came up, and in the meta-analysis, PCI conferred a 5% absolute survival benefit at 3 years. So it is the standard of care in any patient of limited stage small cell cancer who has a complete or partial response to chemoradiation, goes ahead with prophylactic cranial irradiation. You need a MRI restaging after completion of CTRT as per guidelines. It gives the overall survival benefit along with significant decrease in CNSS first site of relapse. Dose is a little lower than the whole brain RT we give for brain mets, 25 grain and 10 fractions. Higher doses have just shown increased neurotoxicity, no improvement, and the volume is whole brain. Just the last thing that now there are trials on hippocampal avoidance whole brain RT in prophylactic cranial irradiation too. And these are two major trials, but very contradicting. So the upper trial is the Netherlands study, which showed no benefit. And the lower study, the Premier, showed an absolute increase in the recall and the memory functioning after hippocampal avoidance. A lot of hush happened, and why two similar populations, two similar modalities, both trials, but why the difference? So the trial which did not show a difference, they said that there was no quality assurance in the hippocampal contouring, and plus the doses that were also not quality assured. That could be one of the reasons. So with this, the guidelines say that considering that we know hippocampal avoidance improves cognition or cognitive function in brain mets, and we have one randomized trial showing improvement, and both the trials, very importantly, did not show any difference in the incidence of brain mets. So it is reasonable to offer hippocampal avoidance prophylactic cranial irradiation as an alternative approach. Thank you.
Thank you, Dr. Ritika. Now I just wanted to invite Dr. Nikhil Pandey, Consultant Medical Oncologist, American Oncology